I'm Professor Kok Hian from KK Women's and Children's Hospital in Singapore. I'm also a member faculty of the Asia Pacific Congress of Maternal Fetal Medicine. I'm actually currently speaking for the Congress itself. The incidence of preeclampsia is about 5 to 8% worldwide. And from our experience in Singapore, it has sort of been constant itself. Although the management of the disease itself has actually varied in terms of the complication rate. So if you manage the disease better, you will have lower complications rate. And one of the important complications relating to preeclampsia is eclampsia, which is the onset of convulsions in a woman who has preeclampsia and hypertension. This is a very dangerous disease. It is a complication that is life-threatening. And in our country, in Singapore, we saw that there is a dramatic reduction of this complication from over 300 per 100,000 women who are pregnant, right down to 16 per 100,000 women. So it's a very dramatic drop, and this is because of the better management we have instituted over the past 20 years. Preeclampsia is diagnosed by having hypertension, the onset of hypertension above a certain value, 140/90, with protein in the urine. We call it proteinuria itself. So once this is been detected, it's considered as preeclampsia. In terms of preeclampsia, actually affects pregnant women, and pregnant women who are elderly, or pregnant women who have a history of preeclampsia before, they are at risk of having preeclampsia itself. Also, first-time mothers, the risk of preeclampsia is also higher. Certain ethnic groups may also have a higher risk of preeclampsia. For example, in Singapore, our Malay ethnic group tends to have a higher incidence of preeclampsia. Yes, of course, very important is the genetic factor. So sometimes some families, they have sisters who are pregnant who have preeclampsia. So genetic factors is involved in this disease. Actually, look at certain, for example, as I mentioned before, our Malay ethnic group in Singapore have a higher incidence. So we target more closer surveillance on this group, especially when they are pregnant. We look out for the preeclampsia group. So it is possible if certain areas have a higher risk, then I think there should be more attention paid to that particular region or the particular group itself. It's very important. For example, if you look at the regions all over the world, we have America, Africa, Europe, Asia. We know in certain parts of Africa, the rates of eclampsia is very high because the preeclampsia is not managed well. So most of the time, the complication is because there is not so good or poor management of the preeclampsia. So, for example, in Africa, the incidence of eclampsia, which is resulting from preeclampsia, goes as high as above 500 per 100,000 women who have actually have the disease, will have eclampsia. Preeclampsia is definitely a very important disease. Preeclampsia, as you know, affects 5 to 8% of the population itself, and it requires, the disease itself requires monitoring, so it requires a lot of costs involved. There was a study that estimated that preeclampsia, when it develops in the pregnancy, increased the cost by 8,000 English pounds per pregnancy itself. And in terms of the economy itself, it actually goes up to billions of dollars that is spent on trying to manage the disease of preeclampsia. So it's a very significant disease that not only obstetricians, but everyone must be concerned about. The challenges is in terms of trying to manage preeclampsia well. Very importantly is that there should be awareness, both by the patients as well as by the healthcare providers itself, in terms of trying to detect, screen for them early, looking at their blood pressure, and if they have high blood pressure, to be able to monitor them closely and even to admit them so that we can treat them with antihypertensive, and also to deliver them if the disease has become so serious. Because if we don't do that, the patient may have an eclamptic fit at home or develop some serious organ failure at home, and when they come in, there may be the life of the mother and the baby may be threatened. And it is estimated that in the whole world, actually up to 80,000 of the mother's death each year is due to preeclampsia itself. And that itself is about more than 40% of the total maternal death for the whole world each year. And also, more than 500,000 babies and fetuses die because of preeclampsia every year. So it's actually a very serious disease globally. Currently, in terms of diagnostic tools, basically in terms of the blood pressure, measuring the blood pressure at each of the visits. And that's why the women have to come quite regularly for visits so that we can detect the blood pressure rise itself. And also checking the urine for any protein. If there's evidence of protein and blood pressure raise, then it's considered as a preeclampsia. So this is the way we diagnose preeclampsia currently. Recently, there has been a lot of interest in biomarkers. The ability of these new biomarkers to be able to predict the occurrence of preeclampsia accurately itself. So two biomarkers we want to mention. One of them is PLGF, which is the placenta growth factor. This biomarker itself is actually reduced when there is preeclampsia, and it's also reduced if preeclampsia is going to occur. So it is a precursor of the preeclampsia developing. So if we can detect that this level is low, then we will be able to predict that preeclampsia is likely to come about, and more attention and more appropriate attention and management can be given to the patient. The other biomarker is S-fleet itself. The S-fleet is the indication of the damage to the vessels inside the mother itself. So this will be raised if there is preeclampsia. It is also raised before preeclampsia itself. So now we use the ratio of the S-fleet divided by the PLGF to give us a very accurate predictor for preeclampsia. And this is a new advancement relating to the diagnosis of preeclampsia. It is very important to be able to diagnose preeclampsia accurately and even before it occurs. And that's why with the development of the S-fleet PLGF and the ratio, this represents a significant advancement in the management of preeclampsia. And I think it's going to change the management of preeclampsia worldwide and fundamentally. Because currently, what we are doing is that based upon our conventional markers, we're looking at markers. For example, we look at the liver function test, the kidney function test itself. These are really almost like the end stage where a really disease is actually happening, and it's actually not a very accurate marker of preeclampsia. But by having these two biomarkers together, we are able to predict even before it occurs, and we are able to actually so-called manage it accordingly. Sometimes when the patient comes in, we are not quite sure whether the patient has preeclampsia. It could have just a bit of blood pressure raise without protein in the urine, or have protein without blood pressure raise itself. And also blood pressure is also fluctuate quite a lot. Sometimes it can be high, sometimes it can be low. So we are not quite sure whether the patient, the pregnant woman, has preeclampsia or not, which is very important. So if we apply these biomarkers, we are able to then realize whether they actually have preeclampsia or going to develop preeclampsia. So in our study here, which I'm involved in, we do a ratio. If a ratio of this S-fleet over PLGF is less than 38, then I can confidently say within 1 week period, this pregnant woman would not have preeclampsia. So I've been able to manage them at home. Rather than to bring them to the hospital, do a whole battery of conventional tests, increasing the cost, and also making the women being hospitalized itself. So this is actually a very fundamental change to the way that we can make towards the preeclampsia management. I think the management of pre-eclampsia has advanced quite a fair bit, especially with the use of better biomarkers. And these biomarkers are very accurate in able to predict the whether eclampsia will occur itself or not. And the level of this biomarker also give us the idea of how to manage this pregnant woman. Because if it's very low, we can actually let them be back home. If it's a little bit high, we will want them to come back for close follow-up. But if it's very high, then we have to do intense surveillance, maybe making them to be admitted and looking at them closely. And it's very, very high, then we may actually have to deliver the pregnancy to resolve the issue. So this is a very important aspect relating to the management of pre-eclampsia.